This is exciting, super exciting. Can everyone hear me okay? I hope that is working. Well, I'm super excited. And I am glad that you're here on Valentine's Day. I've got my heart t-shirt to celebrate. What I plan on doing here today is I got a bunch of questions from my newsletter readers, and I did my best to try to organize them in a way to kind of cover some main themes that I definitely know come up a lot in the rheumatology office for anyone dealing with autoimmune or they think they have an autoimmune condition. So we're going to use the questions as kind of a jumping off point to talk about how to think about things, how to approach things, so that you can end up getting answers and feeling better, right? Because that's the whole point. If you're here, you probably already know who I am, but just in case you don't, and for some reason you stumble into a rheumatology Q&A. My name is Dr. Elizabeth Ortiz. I am a rheumatologist. I've been practicing for over 15 years, and I happen to love rheumatology. And what I have discovered is I love talking. And so I'm doing, I put both together on YouTube in an effort to try to provide a lot of the information that I know we're not always getting in clinic. I also know that the internet is full of a lot of contradictory and confusing information. And so my hope is to just provide some insights. That's it. All right, so let's get started. Got a lot to go over. I am very focused on trying to keep this to an hour. And you'll have to excuse me because I do have my notes, because without my notes, this would definitely go on and ramble forever. So we're going to start with diet and how diet interacts with autoimmunity, how to think about diet. And I did get a number of questions that had a lot of different aspects, but kind of were around diet. And I thought that Tammy actually really summarized everything really nicely with her questions. And so I'm going to go through those questions and then give some context with some of the other stories that I heard to see if maybe it applies to you or you can relate. So the questions are, do you have any patients that are successful at controlling their autoimmune diseases with a whole food, plant-based diet and healthy lifestyle choices alone? Under what circumstances would you support or encourage your patients to try and stop their medications and control their inflammation with diet and lifestyle choices? What risks would you advise your patients of if they are considering stopping their medications? And then what guidelines for diet or lifestyle do you recommend? And then finally, how would your answers change depending on what autoimmune disease that person is facing? So I thought that was actually a really good set of questions. And just for context, she has a story of ankylosing spondylitis in the setting of celiac disease. I also heard from Lynn, who told a story of having seronegative rheumatoid arthritis. And seronegative is, that just means that someone doesn't have all the antibodies that you would typically see with a condition. And when we're talking about rheumatoid arthritis, those two antibodies are going to be the rheumatoid factor, CCP. So having seronegative rheumatoid arthritis, really not sitting well with methotrexate, which is not uncommon, but also doing the autoimmune protocol diet. And then I also heard from Maya, who had a question regarding mixed connective tissue disorder and the use of things like bone broth, turmeric, and ginger. So a lot of good questions about how we can incorporate diet into our treatment kind of regimen for autoimmune disease. And just also a note, in Tammy's story, there was use of pharmaceuticals, also changing of diet, and then being able to get off of that pharmaceutical. And so how often does that happen? So going back to those original questions, have I had patients who've been able to control their disease on diet and lifestyle alone? Absolutely. Absolutely. Diet and lifestyle have a big impact on our immune health. And so as a consequence, if you have autoimmune disease, they have a big impact on that as well. But then you really do need to get into the weeds, into the details. And this is where I think we're not getting the right information on the internet. And this is my main gripe with the information on the internet. You know, we tend to use blanket statements like, all autoimmune disease can be cured by this particular diet. And then on the flip side, our doctor's offices aren't really addressing it either, because it does matter what condition you're facing. And it's not that diet doesn't impact. But when we think about how much of an impact it can have, and what is the likelihood that diet and lifestyle choices alone are going to enable you to become drug-free. And there's this concept we call drug-free remission, which a lot of people kind of think of that as a cure. I don't tend to use that word only because I have seen autoimmunity go in remission for so long and then years later come back. And the idea of a cure, I don't know, I don't use that word. But we do use the word drug-free remission, which is you're not needing any medications and your condition is in remission. So the way we approach it is going to be dependent on the condition someone has. And the things that I think about are going to be what condition it is. Some conditions are more amenable to diet and lifestyle changes, and this is not necessarily documented in the literature. This is based on my experience. Things like psoriatic arthritis, Sjogren's, tend to be more responsive than things like rheumatoid or lupus. But again, I hesitate even to say that because that's painting with too wide of a brush. You're also going to look at what are the risk factors that this particular individual has for having long-term disease. And the risk factors are going to include things like smoking, what are the antibodies that that person has, if someone is seronegative versus seropositive. Seronegative I tend to think that has a better chance of being able to be controlled with diet and lifestyle, but again, not with everyone. And then finally, how severe was the condition when we first met? People who had multiple joints inflamed, people who had to get wheeled in a wheelchair, people who I met in the hospital for the first time, that they tend to be in a more severe category. And although diet and lifestyle still make an impact, I don't tend to be as optimistic that they're going to get complete control just with diet and lifestyle alone. So yes, the way I approach it is dependent on the condition that the person is facing, as well as the flavor of that condition and the severity of that condition. What are the guidelines, the diet and lifestyle guidelines that I'll typically recommend? So I don't typically prescribe to one particular type of diet. I do kind of on purpose use the general words of an anti-inflammatory diet. And the reason I do that is because there are a lot of factors that go into the personal decisions we each make about our diet. There's socioeconomic factors, there's cultural factors, and I do sometimes worry about overly restrictive diets impeding on our ability to live our life. I also think that sometimes, doing that big overhaul of your pantry and going like all in on some particular diet might help in the short term, but a lot of times people aren't able to maintain that kind of diet changes. And so I really keep it really simple. Look at how much sugar, how much processed food you're eating, and start whittling away at that. Start incorporating more anti-inflammatory foods, which are, green leafy vegetables, those kinds of things into your diet. I also kind of use the diet conversation as a jumping off point to talk about lifestyle more broadly, because I have certainly seen a lot of people adopt pretty good diets. They're living their life, but they're not eating a lot of fast food. They're not, eating a lot of junk, and yet still have autoimmune symptoms and still need to see me, still need to be on some sort of medications. And what I've noticed is you can have people with pretty good diets still need to see me. But what I've never seen is someone who has like really good handle of their stress management who needs to see me. And so when I say I use it as a jumping off point, I'm like, yes, let's talk about your diet, where we can make some tweaks. But I'd also like to talk about what are the stressors in your life? How are you handling them? What can we do to address them? Because we need to start looking at ways to lower your general cortisol level and get that sympathetic nervous system, that's that fight or flight, like overactive nervous system that does impact your immune system. How can we kind of get that to calm down so that that will also have an impact on your autoimmune condition, the need for medicines, the risk of flares. So we have to talk about all of it. And this is really highlighted in one of the stories, going back to Lynn's story with the seronegative RA, really not tolerating methotrexate. starting what's it called? The autoimmune protocol diet. And for those of y'all who don't know, this is a lot of places on the internet. It's basically a elimination diet where you eliminate a lot of foods while paying attention to your symptoms, and one by one you start bringing back foods, again trying to find what is maybe triggering your symptoms. It is not a diet that's meant to be long term. It's supposed to be in a short amount of time. I don't necessarily prescribe it. Again, I'm not a huge fan of the overly restrictive stuff, but I have seen it work for some people in that it helps them identify certain foods that are particularly triggering. But what I thought was interesting in the story was, although she had done that and was feeling better, still needed some medication and still having some joint pain. And that is very often what I see. You can definitely gain a lot from these diet changes, but I think we need to maybe adjust our expectations about the likelihood of being able to come off all medications. The other thing I wanted to say just about that story was there was maybe some confusion about like how much we need to tolerate medicines that make us feel bad. It's like, oh, it's a side effect, but I have to take this for a long time. Like, absolutely no. Like, the point of my medicines is to make you feel better. And I'm never going to say that there isn't some side effects that sometimes we have to just learn how to deal with. But in general, if a medicine is making you miserable, then you got to go back to your doctor and ask for other options, because usually there are other options. Now, also talking specifically about the bone broth, turmeric, and ginger. So turmeric and ginger are known to have a lot of anti-inflammatory properties. They are excellent things to add to your, cooking, your spices in your kitchen. Bone broth, I actually had to look up. I mean, I know there's a lot on the internet about bone broth. There was some interesting mouse studies looking at some changes in the inflammatory proteins with bone broth. It's a pretty big leap to go from some cellular changes in a mouse to, curing autoimmune disease in a human. But all that being said, bone broth, turmeric, ginger, any other kind of supplement you want to take, for the most part, the risk is going to be low to making these diet changes. And so I think in those kind of cases, the risk benefit ratio is definitely in your favor. And so if you like eating that stuff, then go for it. All right. It's really hard for me to talk and think about all this and keep an eye on the chat. So I'm going to do my best. The question was about perimenopause, menopause, and those types of changes affecting autoimmune symptoms, and how to address it, how to incorporate that into the way that we can think about treatment for autoimmunity. So, okay. The fact that we're all paying attention to perimenopause, I think, is great. I am worried that with all the stuff on the internet, it makes us think that perhaps we understand it better than we actually do, specifically when it comes to autoimmunity. We have known for a long time that hormones play a role in autoimmune disease, from the mere fact that mostly women get these conditions. But how hormones play a role is still, we don't know. There's been suggestion that perhaps the difference in when women versus men is actually due to the X chromosome. There's obviously different levels of hormones in women and men, but it's not just estrogen, it's estrogen, progesterone, and testosterone. So what's that interplay there? We don't really know. So long story short is, yes, they're playing a role, but we don't really understand how. As far as how to kind of practically approach this, I think what we are now all acknowledging is that we have been underestimating the impact that perimenopausal symptoms are having on us. And when you have an autoimmune condition and you're seeing a rheumatologist for lupus or RA or psoriatic or whatever it is, and you start having these symptoms, it is very easy to underestimate the impact of hormones and overestimate that this is from your autoimmune condition. And although there's no data to support this, my gestalt, my gut is saying that I bet you we had a lot of people who were being overtreated for their autoimmunity because their hormone status wasn't being addressed. So if you are noticing the brain fog and joint pain and body pain and all those things that can be a part of your autoimmune condition, but maybe that's like oh, it feels a little different, or maybe you were really well controlled, but now you're not, it doesn't really make a lot of sense, and you happen to be of that age, and you happen to be having irregular periods, then I definitely think it's worth talking probably with your primary care provider, your gynecologist, because I'm not sure rheumatologists are going to be the best people for this, but talk about doing the testing to see if you're in perimenopause, talking about hormone replacement, in addition to the autoimmunity stuff. So yeah, that's my take on that. Okay, then I was starting to talk about different conditions. People had some kind of condition-specific questions. So GERD, when you have Sjogren's and you're already on 2 acid-reducing medications. So the main 2 medications we use for acid-reducing are going to be PPIs and H2 blockers. Now, we have lots of different types of them, and each one has pros and cons. If you're already on 2 and you're still having problems, then it's definitely time to see a gastroenterologist, because they're definitely going to be the ones who know better the pros and cons of each of the individual medications. So I would definitely see a specialist if you find yourself in that position. We also had a question from Lindsay, who had questions about undifferentiated connective tissue disorder, or UCTD. This is a condition a lot of people end up walking out of their rheumatology appointments with, and it's very confusing. And trust me, it's confusing on our end too. So UCTD tends to be the label that we give when we don't know, when we have a lot of things that point towards autoimmunity, but we're not quite sure which bucket it falls into. Someone doesn't quite fit criteria. It can get confusing because different rheumatologists use this term differently, which just kind of muddies up the picture even more. For some people will have UCTD as their diagnosis for a long time. For others, it'll be temporary. As with more time, symptoms will kind of show themselves, and it'll become more clear. Okay, I thought you were UCTD, but now it's really becoming clear that you're lupus, or it's becoming more clear that you're psoriatic arthritis. The other kind of point I wanted to make with this is, just because you have a diagnosis like undifferentiated connective tissue disease, or sometimes we'll use the term undifferentiated inflammatory arthritis, or in one of my questions, someone said they've been told they had like borderline lupus. It might seem like because you don't have a firm diagnosis that there's no treatment options, and that's not the case. And the way I think about treatment, which I'll have other examples with some questions later, but I think of my treatment options as this big trunk. Like, I've got all of these immune-focused medications in this big trunk that I pull out when someone in front of me has an autoimmune condition. And I look in the trunk, and it's like all the medications are divided up. And I think one of the misunderstandings that we have is that when I'm looking at my trunk and I'm looking at the different divisions, there's an assumption that the divisions are based on disease. It's like, oh, I have lupus, and so I must pull from the lupus pile. Or I've got psoriatic arthritis, I'm pulling from the psoriatic arthritis pile. And that's not actually what I'm doing. What I'm actually doing is I am pulling based on disease features. So my trunk and those medicines are divided based on how good they are at certain features that I don't want to use the word attacking, but at treating certain features. So it kind of doesn't matter what the condition is that you have. Now, that's not entirely true, obviously, but it's not as predominant the issue as the feature that you have, which is why in my videos, I am always talking about how important it is to understand the flavor of your condition, because everyone's going to be different. 10 lupus patients all lined up, all 10 are going to be different. Same with RA, psoriatic, all my conditions. And so understanding what your predominant feature is, or your flavor, and understanding what your priority is going to help me figure out in my trunk of meds which one's going to be best for you. So that means if you have one of these kind of gray area nondescript diagnoses like UCTD or borderline lupus or undifferentiated inflammatory medications, inflammatory arthritis, that means that I still have options, because I'm going to be like, well, what's the main feature we need to go after? Okay, it's inflammatory arthritis. Here are my meds for that. So that's the way I think about it. That's why I also always say, as you are on that journey of trying to find a firm diagnosis, it doesn't necessarily mean that you have to wait for that firm diagnosis to start trying some treatments that can provide some relief. So next question, Allie brought up a great point. Allie has told a story of lupus and summer seasonal affective disorder. Now, seasonal affective disorder, we tend to often think it's like wintertime depression. There is a small subset of people who have the opposite, where their symptoms are more prominent in the spring and summer. And so I think, one of the issues was just talking about it, saying it's a thing, you're not alone if that happens to be you. I also like to broaden it out and just talk about mental health with autoimmunity and really start to remove the stigma that we have with mental health and autoimmunity, and understand that if you really want to have a holistic approach to your autoimmune condition, we got to pay attention to your mental health, because it really, the mind, the body, they're connected. And so we got to pay attention to both. And then the last point, when it comes to lupus in particular, and any kind of summertime symptoms, lupus is known to be very photosensitive. And photosensitivity is not just like I get rashes. It's I feel worn down, I get headaches, I get chill, like I feel like I have the flu coming on. That's what photosensitivity can feel like when you have lupus. And so if someone comes to me and says, I consistently have worse symptoms in the summer, and maybe it's mood, maybe it's more body, then it really makes me think, let's take a look at how we're kind of approaching your lupus, and do we need to do a better job of controlling it? Okay, Sarah brought up a good question regarding rheumatoid arthritis and COPD and whether or not there's a relationship. So my initial answer to this was like, no, and my first thing was to question the diagnosis of COPD. COPD is a lung condition, and it's not on its face known to have a close tie to rheumatoid arthritis. Interstitial lung disease, or ILD, does. And so my first question was, is it really COPD or is it ILD? They're two different things. But then I did a quick search, thankfully, and saw that actually something that had come out just last summer did find a connection between rheumatoid and COPD. And that connection was, when I saw it, I was like, oh, of course, was there a shared risk factor of smoking or exposure to smoke. And so that's kind of how they are connected. Now, it doesn't necessarily mean that one treatment will target both. We still have to address both separately. But I did really like the impulse to think like, hey, these two conditions I've got, I think maybe there's a connection. And I would agree with you. Miss A had a question regarding a condition called Antisynthetase Syndrome. And what is this? How does it relate to other conditions like myositis? So Antisynthetase Syndrome is a rare condition that is a subtype of myositis. Myo meaning muscle, situs meaning inflammation. So there's a whole slew of conditions that are myositis, like dermatomyositis, polymyositis. You can get myositis with lupus, and antisynthetase syndrome is just another type of myositis. It has been newly characterized, meaning we are just still understanding that. Even in like my second, third year out of training, we were just getting a lot of attention. And so if something's that new, that means we don't really understand it that well, and that we're still collecting data to best identify people who have this condition. She also brought up the point of how do myositis without the actual muscle inflammation. That actually happens, which, as you can imagine, makes diagnosing it even more tough. If you don't have the main feature of that condition, then it's even more challenging to figure out if that's actually what you have. Antisynthetase syndrome is characterized by having specific antibodies and by having lung, skin, and muscle disease, but you don't have to have all of them. And so what we try to figure out is, again, what flavor of antisynthetase syndrome do you have? When you get a diagnosis like that, what we're doing in the beginning is just trying to figure out, like, well, what features do you have? And so in that particular condition, that means going after the lungs and like hunting down to see if there's any lung problems. We do that with pulmonary function test, and we do it with a CT scan of the lungs. A chest X-ray is not sufficient. Now, how often do we repeat those tests? That's going to be very individualized based on your symptoms and based on your risk factors. It did bring up, I think, a really important point just about rare conditions in general. Because when you're kind of out in the world and you're going to your local rheumatologist, it is not uncommon to find that your rheumatologist doesn't have that much experience with your rare condition. And in cases like that, I would recommend, if possible, going to the closest academic center that has a rheumatology division for a one-time consultation. At those consultations, they can do a really thorough one-over. They can confirm that, yes, in fact, this is the diagnosis you have, and they can lay out a plan that they recommend that you follow that then your local rheumatologist can kind of pick up and run with. I used to work in one of those types of places and would see people from all over the state who were doing this exact thing. You can also go to places like Mayo Clinic and Cleveland Clinic, but you don't really need to do that. Most states will have at least one big academic center. It's not convenient. It can be a hassle. I understand all that. And that's why I wouldn't recommend that you need to transfer all your care to a place like that. But I think if you really are finding that you're coming up against a lot of walls, that your rheumatologist isn't, you're worried your rheumatologist isn't doing everything that is necessary, getting some guidance and some advice from kind of specialized experts in the field that are usually going to be in those kind of centers, I think is worthwhile. All right. Ooh, lots of people have found me over here. Okay, good. I'm sorry, guys. I can't wait. I'm seeing the chat. I don't see anything. Okay. Okay, sorry, I'm getting distracted. Jane asked about rashes and autoimmune disease, specifically rashes in rheumatoid arthritis, and how do we treat them? So yes, rashes are a big part of pretty much all of my conditions. It was like the joke in our clinic of I would go pull a colleague and be like, can you come look at this rash? Because I mean, rashes are just so common. Rheumatoid arthritis is kind of one of the conditions where rashes aren't as common in RA. We can get some skin changes that look like a rash from a complication of rheumatoid arthritis called vasculitis. That can happen. But the kind of like itchy red rash that we think of isn't really that common in RA. How do we treat it? Well, first we need to determine, is this rash part of the autoimmune condition? And if it is, then really treating the underlying autoimmune condition is going to be the best way to do it. And then, you know, if someone's autoimmune condition is reasonably controlled and they just have a little rash and we don't want to expose them to more medicine, then we'll use some topical steroids, some other topical medications that can calm down the inflammation. So great questions. All right, moving on to tests. People had a lot of questions about all the different blood tests that we run. See a rheumatologist, show up well fed and well hydrated, because they are going to take a lot of blood, because that's what we do. So Margaret had a question about the timing of ESR and CRP. This is the sedimentation rate is the ESR, and the CRP is the C-reactive protein. Her question was about the timing of those particular blood tests in relationship to your symptoms, to maybe different treatments that you've tried, and can they maybe hide stuff? Like, will they change and then confuse the picture and make a diagnosis more difficult? Which I think is an excellent question, because it happens all the time. It really comes up. So if we remember, ESR and CRP are what we call acute phase reactants. They are proteins in our blood that go up and down based on inflammation. They are wildly imperfect, but they are, that word, acute, meaning that they change reasonably quickly. Now, not within minutes, not overnight, but over the course of a few days. And the classic example that always happens is you're having a lot of joint pain, you're feeling really bad, it's taking forever to get into your rheumatologist office, and so you see your primary care doctor and they're trying to help, and so they give you some prednisone. And you take some prednisone and it helps and you feel better, and then you get into the rheumatologist's office and you still have some symptoms, but you're feeling a little better, and they do some blood work and they tell you, well, your ESR and CRP aren't that high. And it's like, well, but I just took prednisone like 2 weeks ago. Like, could that have been impacting? The answer is yes. Yes, it could. And it's just really hard to know. It's really not hard to know how to interpret those results. You try to pull as much data as you can. So like if you have happened to have serial ESR and CRPs done, like, 2 or 3 months ago or 2 years ago, we can compare, and that can be helpful. But honestly, like, those aren't tests that we usually get done if we are feeling fine. So not everyone has years worth of data to look at. So what we end up having to do is we make the best decisions we can with the information we've got in front of us, and then we just follow and watch. And now that you're under the care of a rheumatologist and who can kind of really manage the type of medicines that you're on and understand that and like read your labs, knowing that context, that's how we kind of tease it out. It takes some time, and it can be frustrating. Got a question from Gerline about having positive rheumatoid factor, a low vitamin D, and no symptoms, with the question, should I be worried? With all of my tests, these are just lab tests. Very rarely do they kind of indicate for certain that someone has a condition or someone should be worried. So if truly there are no symptoms, I would say, well, there are no symptoms. You don't necessarily need to keep checking it. I do always kind of question that, because usually we aren't checking these types of labs unless there are symptoms. So I would just really check in with yourself and kind of see if there were symptoms going on and chase the symptoms, not the lab. The other thing is vitamin D being low. So vitamin D does tend to go down when there is inflammation. And I say that with a little bit of grain of salt, because a lot of us have a low vitamin D and we don't have an autoimmune condition. But if your vitamin D is like really, really low and like persistently low, even though you've been taking different supplements, again, I would check in with your symptoms, like you're having no joint pain, you're having no morning stiffness, and kind of think of it that way. But in general, you have no symptoms, then yeah, I don't really put too much emphasis on the blood tests. Okay. And then finally, we have a question about a positive rheumatoid factor. This is from Robin, with an occasionally high CRP and symptoms of Sjogren's. So is this Sjogren's, or could this be nothing? And that, I was like, ooh, that's a good question, because that's a question I have in the back of my head a lot. We definitely don't want to be over-treating just based on blood work. But we also don't want to be missing something. And so this is where we really have to be patient, be observant, be paying attention to your symptoms, to triggers, to diet changes and that kind of thing. And also, when we talk about medications, we've got to talk about how the risk-benefit ratio. So we look at the information we've got in front of us, we calculate how firm that information is. Like, your rheumatoid factor is definitely correlative of arthritis. So we really think you have rheumatoid arthritis, and the risks of untreated rheumatoid arthritis are this. And so that risk benefit ratio of this medication makes sense. But if that calculation isn't true for you, if it's like, well, we're actually not sure if that rheumatoid factor means anything, and you're really feeling well after you've made this diet change and this lifestyle change, and I don't want to mess that up. I don't want to expose you to medications that you don't need. And so maybe this set of medications, that risk benefit ratio isn't in your favor. And so instead, let's do this, and let's just keep watching. I say this all the time, we're always making the best decision we can with the information we've got in front of us. And when new information comes in, we adjust. So I hope that's helpful. All right, these set of questions I thought were great and very, I've been saying that a lot, but it's true. Very indicative of, again, another kind of situation that happens in rheumatology offices especially. And that's this concept that I can't get a firm diagnosis, or my diagnosis keeps changing. And so I had a series of questions from Ian and Patricia and Tracy, all kind of with the same issue. So we had one situation where it started as polymyalgia rheumatica, then became seronegative RA, then because of some platelet problems was diagnosed with myelodysplastic syndrome, and then finally landed on VEXAS syndrome. And so it's like, oh, I've been there. I know that struggle. I know that journey. We have one that started as Sjogren's, then fibro, then rheumatoid and osteoarthritis, and now multifocal fibrosclerosis. We have another story of multiple symptoms, no diagnosis, was told maybe RA, was told borderline lupus, and has no idea what they really have. And then, yeah, Adele also asked, like, how do you approach this whenever you're given every diagnosis, but like no diagnosis? And I love this question because this is something I had to learn how to deal with also on my end, because I was seeing people who came and like, you always have to wonder, like you have a list of diagnoses you've been given that's like every autoimmune condition. Like sometimes that happens, but it's actually very rare to have that many, or to see that journey of like, well, first they said it was this, and they said it was that. So, okay, how do I approach it? Well, first of all, why does this happen? And there's a couple reasons why this happened. Again, going back to that adage of like, we make the best decision we can with the information we've got. And sometimes in the beginning, with the information we have, a certain diagnosis might make the most sense to us. And as time goes on and different symptoms or blood tests come back or they change, then we readjust our diagnosis. And that happens very commonly with polymyalgia rheumatica, because that is a condition of joint pain of the shoulders and the girdle. And so someone comes in with inflammatory shoulder and hip pain, looks like PMR, they kind of fit all the other criteria. And then with time, we start to see more hand and foot issues, which then lead to more testing. And oh, you find they have a rheumatoid factor. And now it's more clear it's actually rheumatoid arthritis. So that happens a lot. You also see it with lupus. All the symptoms will show someone's got lupus, and then more information will show itself with time. Oh, you have some muscle issues, and now you're having some skin issues. And actually, it looks more like mixed connective tissue disorder. So that's one reason why we can get that change. Another reason why is autoimmune changes, like autoimmune changes. Autoimmune conditions beget more autoimmune conditions. And so sometimes conditions just morph. And then finally, you see a different doctor and you get a different opinion and a fresh pair of eyes. And that doesn't necessarily mean that the previous diagnosis or the previous doctor was wrong, but as much as we want to be as scientific about these things as possible, there is still very much an art to it. And so sometimes you get a different opinion, and that can also change the diagnosis. But how can we approach this like practically? Like, I just want to feel better, and which I get. So the way I do it, or the way I approach it when someone comes in with a long list of different conditions and like we don't really know what's going on, is I really scale back and go back to basics and ask, what do we know for sure? Like, forget all these other diagnoses that other people have put on you. What do we know for sure? What are the symptoms that you definitely can see, that we know that you're experiencing? What are the blood tests that we see that maybe have been repeatedly positive? Like, what do we know for sure? Then you take that and you're like, okay, what diagnosis does this best fit? There's usually going to be some symptoms that it doesn't really fit. You're like, okay, well, this person really, they look and smell like rheumatoid arthritis. They've got this blood test that looks like rheumatoid arthritis. They have this rash, though, that looks more lupusy. And so I can kind of see why someone called it lupus. But is there perhaps another explanation? And I use that as an example because, we think of the malar rash as being classic for lupus. Rosacea is oftentimes confused for malar rash. And so things like that, like, are there other explanations for some of these other features that have been called an autoimmune condition? And then I'm looking at my notes to make sure I don't miss anything. And then at the end of the day, I go back to that way of thinking where I'm more focused on your feature than what we call you. And when I'm pulling out my trunk to try to help and offer solutions, even if I can say, well, I think you're more rheumatoid, or I think you're more lupus, or I think you're more psoriatic, and more time will tell, and that's why we need to keep seeing each other. But that doesn't mean that we can't start something, because your main issue is an inflammatory arthritis. Let me pull out a medicine for that. Or your main issue is rashes and hair thinning. Let me pull out a medicine that's better at that. And so we still can work with this even if we don't have a firm diagnosis. So I hope that was helpful in how to kind of think about these very confusing situations. And then finally, we have treatment options, all the different stuff out there. So Anne asks about another PMR question, polymyalgia rheumatica, has been on prednisone for 7 years, flares when it gets below 3 milligrams, and is absolutely besides herself because, like, really, who wants to be on prednisone that long? And I absolutely agree. That's too long. That's way too long to be on prednisone. Polymyalgia rheumatica is a condition that, for the most part, requires treatment for 1 to 2 years. There are people who will need treatment for longer than that. If that happens to be you, that treatment should not be prednisone. We now have other treatments that are more precise, that don't have the same side effect profile as prednisone. PMR is a condition that is an autoimmune condition that oftentimes is treated by primary care doctors. And so if you happen to be in that situation where you're only seeing a PCP, where you've been on prednisone for a super long time, and you can't just get off, then you need to see a rheumatologist, because a rheumatologist will then understand and know and have at their disposal these other tools in the form of other medications that can then take the place of prednisone. So that's what I got to say about that. Finally, we have a question about another PMR, polymyalgia rheumatica, an active 77-year-old who does not want to take steroids and so has questions about using NSAIDs. And so I've got some hard bad news, which is the real treatment for PMR is going to be steroids. And I know everyone hates steroids. I hate steroids. PMR is one of those last conditions. It's like we don't have a lot of other options in the immediate. I know I talked about long-term, but in the immediate, steroids really are our go-to. So when you're thinking of, when you have any condition and you're kind of looking at your options and you're trying to weigh, what road you should go down, I always recommend keeping in mind, not only, we get fixated on the side effects of different medicines or the potential side effects of different medicines, but we also have to put in our calculation the risk of untreated disease. So let's just take this example. So polymyalgia rheumatica, if left untreated, can lead to not being able to walk, like being in a wheelchair, and oftentimes can then blossom into inflammatory arthritis of the big blood vessels. We call that giant cell arteritis. And so that's like not a complication we want. So we definitely want to treat it. Prednisone is very effective, but has side effects: weight gain, osteoporosis, diabetes, high blood pressure. So, it's got its risks as well. NSAIDs, even though they're over the counter, they're not without their risks, especially whenever you're looking at having to take them long term. They cause kidney problems, they can cause heart problems, they can really irritate the stomach. In this case, they don't really do anything for the underlying condition, so they're not really even treating the polymyalgia rheumatica. And so you've got to look at all of those possibilities, including the risk of untreated disease, when you're trying to make your calculation of what treatment sits well with you and what you want to do. Lynn had a question about, I've heard that some patients have been given saline infusions for severe Sjogren's symptoms. Does that work? Do I prescribe it? And does red light therapy work? Okay, so I've never heard of red light therapy specifically for Sjogren's. I did do a brief search. The closest thing I could find is what they call laser acupuncture, focused on the parotid glands and the salivary glands to try to stimulate saliva production. And there was nothing regarding saline for Sjogren's. But I do want to say, I suspect that when we find things like this on the internet, that what we're actually seeing are treatments that are being used for symptoms or manifestations of what is presumed to be from Sjogren's, and they aren't necessarily correcting any kind of underlying immune dysfunction, but are more addressing certain symptoms. And I say that because I see this a lot, and it has nothing to do with whether or not I think it'll help someone or not help someone. That's not what I'm talking about. I'm talking about being as precise as we can with our language, which is really difficult with rheumatology because it is a field of so much gray area. But I think it makes it even more important that we're as precise when we're talking about what we're using and why we're using it. Sjogren's in particular is a condition that can be very confusing, that we do not have a good handle on yet. And so as a result of that, a lot of people will just use the term like, I'm getting this for my Sjogren's, when really what's happening is there might be a manifestation that may or may not be secondary to the Sjogren's, but you might be having a symptom. So when it comes to the saline, what my thought was, POTS syndrome is sometimes treated with saline solution. It's a condition where right now it seems like what we want to do is increase the pressure in our vascular system, and that helps with symptoms. And so saline infusions can do that. And it seems like perhaps there is a relationship between POTS and Sjogren's, maybe. And so I could see how someone has made that leap of like, well, I have Sjogren's and some POTS syndrome, and so someone has used that to treat it, and it kind of comes out with like, well, I'm using it for Sjogren's. Does that make sense? But what I'm trying to get at is it's not really going after saline solutions. Isn't really going after the underlying immune problem. That doesn't mean that someone can't feel better with it. I just want to, again, be as precise with our language as possible. I had one final question I wanted to end with, and it came from Lori, who told a story of having a significant, like feeling really bad, fever, weight loss, really high inflammatory markers. She had a swollen knee. She was just fatigued, just really going through it. And over time, without really a lot, trying to see here, without really a lot of intervention, got better. And it just kind of went away. And so the question was, can an episode like this be just a blip in life, or could something be lurking in the weeds, waiting to rear its ugly head again? Does inflammation and autoimmunity ever act like that? And yes, it does, which, keeps things exciting, but makes things confusing. And again, this is where I tend to take a step back and not get too hung up on what we call things. And we definitely know that autoimmune phenomenon happen. They happen as a consequence of infections. They happen as a consequence of stress, of exposure to certain toxins. And autoimmune phenomenon doesn't necessarily always lead to autoimmune disease. But we don't have a good way of being able to prognosticate that, or of telling like, okay, this is going to be self-limited or this isn't. And once something goes away, if it goes away on its own, it's most likely not a disease, but there's no way of being able to predict if it's going to come back or not. And that can kind of do a number on our mind, as you can imagine. And so we do our best to handle that. If there was a known infection, like, oh, I had the flu and then I got this, and it kind of makes sense, then I feel more comfortable saying this was most likely a time-limited thing. But a lot of times we get these exposures or these infections and we don't know. So I did want to kind of end with this final thought on using these things that happen to us as a reminder to take care of ourselves. There is no guarantees ever, right? There's no guarantees ever, whether you have an autoimmune disease, whether you have autoimmune phenomenon, whether it went away, whether it's not going away. Like, there's never any guarantees. And there's, I think these are always good reminders that we need to be taking care of ourselves, which I think in our modern world, a lot of us tend to forget to do. We're either taking care of others, or we're busy doing other things, or we've got to pay the bills, or whatever it is. And these types of conditions and symptoms and phenomenon or whatever, they tend to stop us in our tracks. And it's just always a good reminder that we need to, take care of ourselves the way you would want to be taken care of when you were a kid, or the way you would take care of your kids, or whatever. Okay. Oh my goodness. I see so many questions. Yeah. Thank you so much. UCTD, dsDNA, no signs of full bloom. I know it's confusing. I know. Yeah, the dsDNA antibody is an antibody that is classically thought of as being pretty specific for lupus. With that being said, it depends on the lab that did it. It depends on the quality of the test. It depends on how high it is, and it depends on your symptoms. And so it's really hard to say that every positive double-stranded DNA means lupus, and it is very confusing. I'm glad that you're feeling better. All tests are normal. That's great. If you have POTS and Sjogren's, will Plaquenil help? That's a very good question. I think, I must be coming out sometime in March, because I just filmed a Sjogren's video about Plaquenil, where I mentioned Plaquenil. And long story short is we oftentimes would use it in the past. And then a study or a number of studies came out when I was in training or early on that basically said it didn't do anything. And that when we were using Plaquenil, we were mainly treating ourselves and not the patient. Now, that doesn't mean that that's going to be the case with everyone. It depends on what your symptoms are. But we just need to adjust our expectations whenever we're using Plaquenil. Would you see an ANA homogeneous in Hashimoto's? Yes, you would. Yes, that could very well be because of the Hashimoto's. Still need a full, my opinion, I would still do a full head to toe, up and down, make sure there's nothing else going on. But if all that checks out, then the ANA is probably because of the Hashimoto's. All right. Yes. So thank you guys. Oh my God, did it. Now it's Valentine's Day. Now we can go have our Valentine's Day and our long weekend if you happen to be here in the States and get Monday off. I do not. So have a great day. Thank you so much for all your support. I hope you found this helpful. I'm hoping maybe I can do this again. So if you want to get your question in front of me, then it's probably best to join the newsletter. Otherwise, have a great day. Have a great weekend.